For our closing keynote address, we have Dr. Julie Zissimopoulos. Dr. Zissimopoulos is a professor in the Sol Price School of Public Policy at the University of Southern California and senior fellow at the Schaefer Center for Health Policy and Economics. She is a principal investigator of the other USC's Resource Center for Minority Aging Research, known as USC AD RICMAR, and a Center for Advancing Sociodemographic and Economic Study of Alzheimer's disease and related dementias, both focused on reducing burden of Alzheimer's disease and funded by the National Institute on Aging. Her research focuses on innovation in AD treatment, drug therapies for conditions that influence risk of dementia, racial and ethnic disparities in dementia diagnosis and treatment, and using Medicare claims and survey data. Please all join me in welcoming Dr. Julie Zissimopoulos.
Thank you, Dr. Ingram, for the introduction, and thank you to Dr. Friedman for the invitation, and Quentin McCollum for his great support. I also want to thank the speakers who came before me. I really enjoyed learning from you today. I'm going to share my screen and get us started. Okay, I hope you can see my screen. Shout if you cannot. So I'll start with acknowledging and thanking the National Institutes on Aging for support of this conference, and really the RICMAR programs overall that make meetings like this one possible. I also want to acknowledge support for my research through the grants listed below on this slide. So we started by hearing excellent talks about exciting opportunities to use registry data for dementia research. And what I hope to do is to add to the conversation today how we in the social and behavioral sciences are looking for opportunities to slow the development of dementia, reduce its social and economic impacts, and promote dementia health equity. And I'm going to do this by examples of research that my colleagues and I are conducting. And along the way, I'm going to try to point out research areas that I view as high priority areas for future research. And as Dr. Ingram noted in the introduction, my colleagues and I primarily use survey and administrative claims data. And as you heard, claims data and other surveys are often linked to registry data. And I think that combining these richness of the registry data with claims data can really provide some important insights into healthcare use and costs and family impacts, and really provide some unique opportunities to better understand disparities and promote dementia health equity. So I'm going to start by introducing my research team of economists, health policy researchers, data analysts, and students. And the team also includes, importantly, collaborators from outside and within USC from basic and clinical sciences. And it is really their contributions that is informed by the biological underpinnings of the diseases and clinical care that really supports our own social science research. So listed here are a set of questions we ask around risk, population rates of disease, dementia diagnosis, care and health equity in care, health and other outcomes for diverse persons living with dementia, and the impact of innovations in treatments of Alzheimer's disease and other dementias. And I'm going to organize this address to you around research that answers these questions, but I want to start off with just a little bit about the data. So this data briefly describes different data types, examples, and notes just a few strengths and limitations of each. It is not meant to be comprehensive, but illustrative. And what's important to note is the data sources and what you choose for your research, they differ in several key areas. Importantly, how dementia is measured, the sample size and representation, its usefulness for assessing heterogeneity across racial and ethnic populations, and other characteristics we might be interested in, and the richness that it contains around other health conditions, social and economic, environmental, and contextual factors. So I'll just make a few points about Medicare healthcare claims data. So there are 65 million US adults enrolled in Medicare today, about half in what we consider traditional Medicare. So you go to the doctor and Medicare is billed for the services, and half in Medicare Advantage. And Medicare Advantage is another way persons receive Medicare coverage. The plans are offered by Medicare-approved private companies, and they must follow the rules set by Medicare, and most include drug coverage. And they're very distinct in many ways that they provide care and the access to doctors that you have. And I'm going to return to that at another point later on. So a key strength in these data for health equity research is large populations of different racial and ethnic populations. And another strength is measurements of healthcare use that's not subject to the bias known to be more prevalent in self-reports. Dementia is identified by diagnoses, and I'm going to return to this issue and limitations and perhaps ways of reducing those limitations later. Also important to note is the data are for billing and payment purposes. So they have limited other measures around, say, socioeconomic status, but there are opportunities to measure other contextual factors using zip codes of beneficiaries that are available in claims data. And of course, as mentioned earlier, linking them to registry and survey data. National representative studies like the Health and Retirement Study are another key source for population estimates of dementia. And the study has innovated in the area of measuring mild cognitive impairment in dementia using something called the Harmonized Cognitive Assessment Protocol, often referred to by its acronym HCAP. And when combining this innovative measure with measures of socioeconomic status and other contextual factors, it really opens up opportunities to study social determinants of health and dementia. But a limitation is small and sometimes non-existent sample sizes of some racial and ethnic populations, in particular American Indian, Alaska Native persons and Asian persons. I do want to note that the HRS does link to administrative claims, which offers opportunity to ask and answer questions that are not often well answered by one source alone. So with the stage setting and data behind me, I'm going to move on to, I think, the more fun part. And we'll start with thinking about the first question I posed, opportunities to reduce risk of dementia through the study of social, economic, psychological, biological, medical pathways, and across diverse populations. So the life course model that I've put on this slide here is really meant to just illustrate that these pathways are both along individual level and systemic, institutional, historical systems levels. And then also that when we think about risk, we think about it from a life course perspective, and you see that along the x-axis. So in this first example of pathways to risk reduction, a colleague of mine at USC, Dr. Eileen Crimmins, compares the relative contribution of genetic, biological, demographic, and social factors to cognitive function using a cross-section of the Health and Retirement Study and using that new measure I mentioned, HCAP. And what is, I think, notable in her study and illustrated here is that only about a quarter of the variation across individuals is explained. And genetics and biology account for about less than 5%. The majority are demographic and social, economic, other factors. So their findings suggest that while the biological and genetic information that they have available in their HRS is a useful addition to the toolbox when we think about predicting health outcomes later in life, these other factors, demographic, socioeconomic status, mental health, health behaviors, remain equally, if not more, robust predictors of cognitive dysfunction. So what I want to turn to now is potential clinical pathways to dementia risk reduction via drug therapies for non-dementia conditions. So I'm going to start with just spending a few minutes with an overview of our research group's approach to this area of study. So we started by convening a panel of experts from basic and clinical and pharmaceutical sciences to aid us in identifying and prioritizing what drugs should we look at. So for example, those that are hypothesized to reduce risk, like statins and antihypertensive and antidiabetics, anticoagulants, as well as those that are hypothesized to increase risk of dementia, such as antispasmodics and benzodiazepines. So we looked at the literature, completed a scoping review that included 29 different drug classes from 400 studies. And what was notably missing from almost all of these studies were analyses of the effect of drugs on dementia risk by sex or race. So we looked to design studies based on a drug's hypothesized mechanism of action. So both on the pathology of Alzheimer's disease or another dementia, and then also through the effect on the targeted disease. For example, antihypertensive therapeutics efficacy in reducing hypertension, given that hypertension is a risk factor for dementia. And we leveraged the strength of Medicare claims data to examine potential differences in a particular drug class's effect on dementia risk across different race and ethnicities. So I know that's a lot, but let's look at an example and hopefully that'll make that a bit more clear. So in one study, we looked at antihypertensive medications for insight into how might we reduce population risk of Alzheimer's disease through the consideration of what antihypertensive is given and for whom. So I'll begin with a statistic that was talked about a little bit earlier, is the percentage of older adults with hypertension. So in Medicare, that's about 75% of older adults, and it is a risk factor for dementia. And most older adults with hypertension are treated with an antihypertensive, but not all antihypertensives are the same. In particularly, those that act on the renin-angiotensin system, I'm going to call them RAS, RAS-acting antihypertensive medications. So these are your ACE inhibitors and your ARBs. They may modulate numerous protective mechanisms against Alzheimer's disease, independent of blood pressure effects. And this is primarily based on animal and human studies by our collaborator on the study, Pat Kehoe. So while both ARBs and ACE are RAS-acting antihypertensives, ARBs are also hypothesized to be more protective than ACE inhibitors. And again, this is based on work by our co-author. And finally, RAS-acting antihypertensive agents function differently in Blacks compared to whites. So we looked at these hypotheses and we tested them. And we tested them using 7 years of claims data. So parts A, B, and D, so that's inpatient, outpatient, and drug claims. And so moving now to the results. So the results that you're looking at here are odds ratio of Alzheimer's disease risk for these RAS-acting drugs, so that's our ARBs and our ACE inhibitors, relative to our non-RAS-acting antihypertensives. So think about calcium channel blockers or diuretics. And what we see is the use of RAS-acting antihypertensive compared to non-RAS-acting drugs are significantly associated with reduced risk for males, but not females. And when we look across race and ethnicity, we see that the association is largely driven by white males. So we don't see the same effect across race. So then we look to the second hypothesis that was posed, which is that ARBs are more effective than ACE inhibitors in reducing risk. And this is what this table shows: the difference between ACE and ARBs relative to those non-RAS-acting antihypertensives. And we found that the protectiveness against dementia risk was mostly driven by the ARBs, actually entirely driven by the ARBs. And there was no significant association with ACE inhibitors and Alzheimer's disease risk, regardless of sex or race ethnicity. And of particular interest is the reduced risk for Black females. And why I say it's particular interest, because historically, ARBs have not been the first line of antihypertensive treatment for Black persons. So this study requires replication and follow-up. However, the implication is that we may be able to reduce the population risk and the disparities in risk through consideration of something like what type of antihypertensive medication we use to treat antihypertension and for whom. So moving on to question 2, what is the prevalence incidence of dementia in the US population and across different racial and ethnic populations? So as we've heard earlier, quantifying the rates of disease in the population is really the cornerstone of planning for the well-being of the population, whether it be the nation or a particular state. Quantifying it for dementia or a particular etiology, such as Alzheimer's disease, is challenging in surveying claims data for data limitations and measurement reasons discussed earlier. That is, we do not have a robust dementia surveillance system in the US. So for population measures, our 2 key sources are nationally representative samples and Medicare claims. So strength of Medicare claims is the ability to measure dementia incidence and prevalence for older populations over a long period of time and across different racial and ethnic populations. Particularly notable is the ability to measure it in Asian and American Indian and Alaska Native populations. but limitations are the identification through diagnosis codes. That is, persons living with dementia are not identified if they're not captured by the healthcare system claims records. So we do the best we can, and one way that we do that is through the development of an algorithm. And we've made this algorithm publicly available to support the research community. And I just want to make a few notes about the features of the algorithm and then talk about what we're finding with respect to incidence across racial and ethnic groups. So about the algorithm. So we use dementia diagnoses codes, and we use them across all healthcare settings. And we also include Part D codes for drugs that treat the symptoms of dementia. And I have them listed here on the slide. And in addition, we use codes for MCI and other dementia symptoms such as aphasia, where the latter two are just used as verification of a diagnosis of dementia and for timing purposes when we think the first incident diagnosis occurred. So we track codes over time and require a second code to exclude rule out diagnoses. So what the graph is showing here is 3 versions of the algorithm, but they all require at least 2 claims. And there's a few key findings that are worth noting. So we do see that incidence is declining over time, and this is consistent with findings from other cohort studies. An exception, as you see, is for American Indian Alaska Native populations. This may be a signal of rising rates of dementia in this population, but it may also be due to better detection. But there is a paucity of large studies of incidence in this population to compare it to, and this is definitely an important area for research. Another finding was that the use of drug codes was important, particularly for identifying Asian and Hispanic persons with dementia. And again, the drugs codes that I used are noted here. So I want to briefly now turn to prevalence. And what the prevalence figures here are comparing is the prevalence of dementia based on diagnoses codes to a validated dementia measure based on the telephone interview for cognitive status and proxy reports from the Health and Retirement Study. So we do see a difference between these 2 dementia measures when we're thinking about prevalence in 2006 for men, but we don't see that difference statistically different in 2012. And we found no difference between these 2 measures of prevalence for dementia in women in either year. But these data are old, they only go to 2012, and they only compare the diagnoses of dementia for persons in traditional Medicare. So the next study that I want to talk about includes 2 important innovations. First, the darker bars on the right are from a study by Dr. Manley and colleagues who report dementia prevalence in 2016 based on that new harmonized cognitive assessment protocol that I mentioned earlier. And then the lighter bars on the left represent diagnoses of dementia for all Medicare beneficiaries. That is, all of those in traditional Medicare and all of those in Medicare Advantage plans. And this is based on newly available data that CMS has provided called Encounter data. So now we have all Medicare beneficiaries. And what we find is that overall, dementia based on diagnosis claims is just about 8% prevalence in the population 65 and older, while based on HCAP, it is 10% or about 2 percentage points. So that's about 20% of the population not diagnosed. And this is still a significant proportion, but is far less than prior estimates have reported. The estimates confirm prior findings that underdiagnosis is larger among Blacks. However, interestingly, we do not see a difference among Hispanics. And what is possible using the sample of all Medicare beneficiaries is to look at prevalence in Asian and American Indian Alaska Native populations with a prevalence rate of 6.7 and 8% respectively. So again, thinking about comparisons, there was a recent study using the National Health and Aging Trend Study, and they reported a 9% prevalence among American Indian Alaska Native populations. But again, I'm going to repeat that definitely more study is needed here. So now I want to turn to improving early detection and diagnosis. So we are pretty familiar with the potential benefits of early detection. It allows both clinicians and patients to begin to prepare for future needs and identify treatment options. And this is becoming increasingly important with amyloid targeting drugs, including the FDA's recently approved lecanemab for Alzheimer's disease. One criteria for this drug and for those that are coming down the pipeline is patients are in early stage disease. But we have no national screening program for cognitive impairment or dementia, and the US Preventative Service Task Force concludes that evidence is lacking for one. However, one thing that we do have is something that came with the Patient Protection and Affordable Care Act of 2010. It provided a new benefit for an annual wellness visit to all Medicare Part B beneficiaries starting in 2011. And the ACEI mandated that this annual wellness visit, I'm going to refer to as AWV, includes detection of cognitive impairment annually, along with other checks such as blood pressure, weight, medical history, other routine services. So the annual wellness visits require detection of cognitive impairment may increase dementia diagnosis, but there are considerable barriers to this link between this required detection at the AWV and getting to a diagnosis. First, we can look at who actually has an annual wellness visit and who reports receiving a cognitive assessment at it. And that pie chart in that top corner there shows for you that first 45% of older adults eligible for an annual wellness visit report never having had one. Another 30% report having an annual wellness visit, but no cognitive assessment. But annual wellness visit use is growing over time. And against this backdrop, we studied if the annual wellness visit has had an impact on the diagnosis of dementia. Now, there are several methodological challenges in assessing this. The first one being that as the number of annual wellness visits have grown, dementia incidence has been declining. So the raw correlation is negative. But more importantly is selection. Those who get an annual wellness visit are different than those who do not. And for some of these reasons, we can control for in our models, but some of these reasons may be unobserved. So we use a technique, instrumental variables, to address these sources of bias. And what we found was a pretty small impact of annual wellness visit on dementia diagnoses. But interestingly, a notable difference by race and ethnicity. The effect was only positive for whites and Blacks, and largest among Blacks, and there was no effect among Hispanics and Asian persons. So unpacking this black box of what happens at the AWV and thinking about health policy and healthcare system ways to improve it, and how and why it may or may not lead to better detection and earlier detection of dementia is definitely an important research area that I'm interested in highlighting here. So thinking about care and health equity in care, people living with dementia are most often diagnosed and treated by primary care physicians. But in their life, they're treated by numerous other medical specialists for both their dementia and other conditions as their disease progresses. So high priority research is focused on ways to improve quality of care received by persons living with dementia and how we can do this without significantly increasing cost. So over the next few slides, I'm just going to describe some disparities in care for persons living with dementia that our group has studied, but the why is still a wide open research question. So here, this graph shows healthcare follow-up visits for Medicare beneficiaries 1 year after their initial dementia diagnosis. And we show it by physician specialty, which we've grouped here into non-dementia specialists and dementia specialists. And then the color-coded shows across different race and ethnic groups. And in this study, we found few persons with a new diagnosis of dementia had a healthcare visit with a dementia specialist within 1 year of diagnosis. And only one, this was about under a quarter and was lowest for Asian persons. We also found that one third did not have any follow-up care visit for dementia within 1 year of diagnosis. And this again was higher for Asian and Hispanic persons than white or Black persons. Another aspect of dementia care is the use of drugs that treat the cognitive symptoms of dementia. And again, I've listed them here. It is more prevalent among white patients than non-white patients. And in terms of timing, Asians are more likely to initiate before a dementia diagnosis, which is consistent with some of the discussion we heard earlier around issues of stigma. And more recently, we analyzed care during the pandemic, an area of inquiry that Maggie Miller pointed to earlier. And more specifically, we examined the care received by persons living with dementia after a COVID diagnosis compared to matched persons without dementia. And we found across persons living with dementia of different races and ethnicities, all experienced worse outcomes after COVID diagnosis than matched persons without dementia. That is, they experienced higher mortality within 30 days of a COVID diagnosis. And that's also for those who are hospitalized and non-hospitalized after a COVID diagnosis. Again, pointing to another priority research area. We don't know why. We know that they did experience worse outcomes. And now I want to turn to outcomes. So there's substantial heterogeneity and lifespan with dementia, differences in the progression of symptoms of disease, and these have financial and health impacts for persons living with the disease and their families. We examined racial and ethnic differences in lifespan, but before turning to this example, I want to point to other important areas of study, including the financial costs for persons living with dementia and their family, and the study of outcomes that are important to persons living with dementia and their family, identified in other studies such as relationships, safety, independence, and purpose. So in this study, we took advantage of the very long panel, 18 years of data on Medicare beneficiaries after a dementia diagnosis in 2001. So we followed that cohort who were diagnosed in 2001 for 18 years. So we have an accurate information on the date of diagnosis and the date of death. And we quantified the difference in years lived after dementia diagnosis for different racial and ethnic populations. The left bars show mean difference, while the model on the right adjusts for other factors, but it tells the same story. Asian and Hispanic persons live longer on average after a dementia diagnosis than white, Black, American Indian, and Alaska Native persons. And this length of life difference has very important implications for the financial and care planning of persons living with dementia and their families. So I want to turn now to the impact of innovation in treatment for Alzheimer's disease. That is focusing on the future health and the future healthcare costs of the population. And I'm going to do so by using a tool that we have been developing over decades at the Schaefer Center. And it really can help us understand the population impacts of innovations and treatments and just changes in population health more generally. So what we did was develop a dynamic microsimulation for Alzheimer's disease. And it takes in data from primarily the Health and Retirement Study, but other data sources also. And with it, we model how middle-aged and older Americans age. That is, we estimate the health, social, economic, and demographic factors that are associated with onset of disease over the life course. So diseases such as hypertension, diabetes, as well as dementia, and estimate the factors associated with mortality. So a key feature of the model, besides taking into account many different factors, is that it takes into account the competing risks of disease. It accounts for their correlation. So with it, we quantified the prevalence of dementia, healthcare costs, and we aggregate these individual level data and modeling to the population. And with that, then we can simulate the future prevalence of disease, taking into account the changing health profiles of entering cohorts of individuals at middle age. So that is, we can take into account that those cohorts that are coming into middle age have some different characteristics. They smoke less, but for example, they have higher BMI. So we use the model to project Alzheimer's disease prevalence and costs into the future. And then with that, we can compare what if scenarios. And so in the example that I'm going to show, we ask, what if we can delay the onset of Alzheimer's disease by 5 years? So not prevent it, just delay its onset. And what we found was that without any new Alzheimer's disease treatment, the projected US population with Alzheimer's disease will double by 2050 to 9 million. With a new Alzheimer's disease treatment that delays its onset, the number of Americans is reduced by 41%. And the box on the bottom shows some differences across race and ethnicity. Without a treatment, costs are projected to be 1.6 trillion in 2050 and reduced by 640 billion with this delay. So that's from the societal perspective, but we can also ask it from the perspective of the individual. For an individual, what is the lifetime value of this hypothetical new treatment? So we ask for a 70-year-old who would over their lifetime go on to get Alzheimer's disease, what is the value? And we quantify this at 475,000. And so this is essentially a value of additional 80 years of life, and then takes into account fewer hours of care provided by family, and then any change in healthcare costs associated with longer life, but fewer years with Alzheimer's disease. So this is a hypothetical possible, and we are not there yet. And we are currently using the model now to look at and quantify the impact of lecanemab, a currently approved treatment under accelerated approval, and only reimbursed by Medicare under coverage with evidence development, that is for those in clinical trials. So with the model, we can use clinical trial data on efficacy, that is the slowing of cognitive decline and functional limitations that are studied in the Clarity AD trials. And we find that our preliminary estimates place a 3-year value of this current treatment for an individual at about $21,000. And again, that's based on quality of life and fewer care hours required. But what I really want to look to now is the future. So the momentum is really building for the impact of research to inform risk reduction and identify opportunities to improve the lives of the person living with dementia and their families. And this urgency has not declined. I would say it's only increased since Dr. Alzheimer first described the disease in 1906. So through this talk, I noted a few high priority research areas, but there are many other priority research areas that are emerging with changes. And there are important changes that are happening to insurance design and reimbursement. There are important changes happening with respect to how we detect Alzheimer's disease, for example, through blood-based biomarkers. There are new treatments, and they're more in the pipeline. And there are coordinated care models that are being developed and tested and implemented in various settings. So there's a lot of research to do, and I hope you are all inspired to do so. So I want to first encourage you to connect to the RICMARS for early stage investigators. And I also welcome you to connect to me through the other centers that I am associated with, the Aging and Demography Center, acronym ACES-ADRD, and our Aging and Cognition Research Program. And I would like to acknowledge my co-authors and collaborators, some of who were in the picture earlier, but not all were in the picture. And with that, I'm going to thank you all for staying with me to the very end. And I really welcome your questions. Let me stop sharing and come to, so I can see everybody.
Fantastic, Julie. Thank you so much for, again, what a breadth of information that you shared about the productivity that's going on in your center there. So we do invite questions from the audience. I know here in our room, we were already drawing a parallel between your presentation with our opening remarks from Dr. Julius Fredrickson about the future of treatment for AD and dementia care. And so certainly we've seen throughout the day some interesting running themes across the different presentations. So I'm very good on you there. Any questions or comments? I have one and I'll start. You mentioned a lot of priority areas, and at the beginning of the presentation, I thought, gosh, how is she going to get through all of those? And you did that expertly. I wonder if you can talk about maybe some priority areas that are on the horizon that either your team is considering or may be better suited for other teams based on what their strengths are.
Oh, thank you, Dr. Ingram, for that question. So one thing that I had mentioned at the very end that we are interested in and have been looking at is this changes to reimbursement and benefit design. And so I mentioned earlier that one important change that has happened is the number of Medicare beneficiaries and Medicare Advantage plans. So we're up to almost half and half now. And Advantage plans are different the way that they're set up in theory to coordinate care, but there's also incentives to hold down costs. So we are very interested in trying to understand how that benefit design and reimbursement system affects both detection and diagnosis of dementia, and then also the care and what happens to persons with dementia after they're detected. And, along with sort of traditional things that we think about that happen in managed care, some of them not being good, some of them being okay. There's also, a lot of new benefits that are being reimbursed in Advantage plans. So some of them are health related, but they're also non-primarily health related benefits, like access to transportation that's not just to go to a doctor's appointment. And so we don't know yet who's using these benefits, if they're being beneficial, if there are big disparities and who has access to them. And another, I think, important point to note is that the beneficiaries that are in Medicare Advantage plans are disproportionately non-white. And so if we're thinking about health equity, we really need to think about these, different care systems that exist and how they're providing care. So that's definitely one area that that we're thinking about as we move into the next stage of our research.
Very good. Thank you. We do have a question in the chat here. Can you speak to efforts of building up the capacity of fragmented pipeline of data collection, either through Medicare, births, disease registries, et cetera, to nationalize Alzheimer's information?
That's a great question.
Yes.
I think what I can say is that there has been a big effort at the National Institutes of Aging to address this. There are funding opportunities that are just out now that are asking for people to develop platforms that researchers can go to that has this information accessible and in one place. So I guess I can only say that I agree that we have fragmented information and that bringing it together and making it, I'll call it more democratized, bringing it to everybody is a really important step forward. But it's very, I think, encouraging to see that that this effort is being funded by the federal government to support this, recognizing this is a really important area for progress.
Yes. Thank you, Kim. Bernie, I saw you unmute. You have a
Yeah,
question?
I didn't put it in chat. Wonderful presentation, Julie. Thank you.
Thank you.
With the increase in managed care and the advent of what essentially are gatekeepers to managed care, that those people who are incentivized to limit managed care, I seem to think that there's just an extra hurdle that's been placed for people, especially those caregivers and the people they're caring for, in terms of accessing this care. And I don't want to throw a grenade in your lap, but that seems to be such an important issue, and I just don't know how we're going to deal with it.
Oh, thank you, Bernie, for that observation and question. So what we have seen in other disease areas that have studied this gatekeeping, we definitely see lower use in some healthcare settings, hospitalizations, some services, and then you see some increases in sort of prevention and some access to other. So I agree with you. I think this is going to be an important issue. What we don't really know much about is how that gatekeeping affects persons living with dementia. We've seen the studies in other areas. We haven't seen it much here. So I think that, as we move forward, specifically with this Medicare Encounter data, now that we can access it, we'll be able to get some insight into that and be able to see how does it affect people's lives. Now, one thing that I will note that I think we're going to want to see, that's going to be hard to see with our claims data, is we can see how it impacts people's lives in terms of things we can measure in claims data, their healthcare use, death, but we don't see things like quality of life. So we're going to have to be a little bit creative, and I think maybe this is where registries and other sources of data are really going to be able to play a role, is when you can link these other important outcome measures with these differences in way care is managed in Medicare settings. So we can really get at the bottom of that. But thank you, Bernie. I think that was a great question. And it's
You're welcome.
definitely
Thank
something
you.
that's on my mind.
Yeah, absolutely. Thank you.
Thank you, Bernie. And I inadvertently skipped a question from Daniela and comment. I also think about the caregiver burden theme and financial burden that has emerged throughout the day. Engaging caregivers, of course, will be important. What additional data might we need specifically from caregivers to move the ADRD work forward? There has been a lot of engagement with caregivers, but I know that even more is needed.
Thank you. That is a great question. I actually have to say that I recently was part of the NIA Dementia Summit. I don't know if anyone had a chance to join that. And one of the most powerful parts of that were these lived experience panels where persons living with cognitive impairment and dementia and their caregivers had a chance to talk about what was important to them and things that they experienced, their lived experience. And the impacts on caregivers is so multifaceted. And I think one of the areas that still needs to be studied, we think a lot about well-being and healthcare, but what came out on these panels was this financial impact, this really, really long arm of financial impact. So a caregiver who's an adult child has impacts at the workforce, the productivity, on their own wealth, their own income, their children. And so this thinking about the support for caregivers from a financial perspective, I think is a really, really important area of research and an area where health policy really needs to evolve to address it. And if you did not have a chance to attend the summit, all of those presentations are available through the web, and I highly encourage you to look at, especially those lived experience panels. They're really insightful and I think important for us researchers to hear.
Absolutely. And then thank you, Sue. Sue Lefkoff has a comment and question here. Thank you, Julie. Interesting about the annual wellness visits. Having had them and never having been asked about anything related to cognition, I also wonder whether patients might refuse to be tested. And I also, I'm curious as a child of an aging parent as well, and knowing that my parents don't live near me geographically, right? When I'm asking them about how their well visits are going and wondering about what's happening during that encounter. So any insight you have on that is great.
Yeah, thank you. So this annual wellness visit from a data perspective is pretty much a black box. So one thing that colleagues and I did was so the results I showed you around, did you get a cognitive assessment, was based on a survey. And what we did was we, asked if they received a structured test, so something like, a mini med or an one of the myriad assessments that can happen, or if they were asked, do you feel like you're having trouble with your memory? Are there any concerns, or nothing? And what was really striking is the very low use of the assessment, an assessment tool. And we know something about why that is. There are, there's barriers in the healthcare system to using those tools. barriers around how to use them and how to interpret their results. It's not really part of practice, and it's time consuming. And the way physicians get reimbursed doesn't necessarily account for the time it takes to do a good assessment. So sometimes it's as little as, do you have concerns with your memory? It's not very often that a structured test is given. There's been some interesting work by researchers thinking about, well, do we need a better way of kind of thinking about who's at highest risk and prioritizing and targeting this a structural cognitive assessment for those individuals. I, like you, ask my parents every time they go to their annual wellness visit what happened. And disappointingly, the answer is always, well, they did ask, like, oh, am I concerned? I said yes, and that's where it stopped. There was no follow-up. So that tells you other things to look into too. So even if an assessment is given, what happens? Like, is there a next step? Do we get to detection? Do we get to diagnoses? So I just encourage this as a really important area that I hope people can find innovative and creative ways to look into.
Absolutely. Great questions. Any other questions? Kim, yes, go ahead.
Hi, I'm going on screen because I think it's part of the question. I tried to ask this at the end of our breakout session, but we had such good conversations, it didn't get really answered. And so it's not exactly for you, our keynote speaker, but generally, if you wanted to take a stab at it, if anybody else wanted to try to answer. A theme of today has been like to diversify the data, to diversify our research, to engage with our community, like with the community and not just kind of swoop in and swoop out. As a person who outwardly looks differently than many of the people I would like to help, but like still a valuable person to the cause, how would you suggest engaging in research? Because obviously research needs to be done, and the more people who are allies and bring people to the conversation and educate is really important. But this is a global problem, and we're all here in America, which has got great resources, but we still have disparities and there's problems all around. So how do you begin as a researcher beginning to address, obviously there's some privilege that we have, but like joining other communities to help engage in more meaningful, inclusive research? That's a big question.
I don't know, Kim. Well, first of all, thank you, Kim, for coming on screen. I always appreciate seeing faces when I'm engaged in these Zoom conferences. So I don't think I'm probably the best person to answer this, but I can tell you sort of, I'm an economist. I work with population data sets, secondary data, but I acknowledge and value what you said. And so the way that I have tried to like engage in communities or figure out how to do better research by engaging in communities is really through partnerships. So partnerships with other universities, research groups, and community groups that do that really well. And so take what I think that I have some expertise in and join it with their expertise. So if you're a researcher who doesn't have those connections but wants to get them, that's one pathway. Then, or find the collaborators, who are doing that, and have invested in relationships with community to answer these questions that we can't answer with our national population data sources. I don't know if that answered your question, but I open it to anyone else to jump in.
Yes, this is a great question, Kim, and I think you're right with your preamble that this is probably bigger than this one presentation and even certainly this entire conference. But I would like to take it back to some of the anecdotal yet very powerful, statements that Greta Brown made this morning, right? And so in terms of trying to engage community, it has to be bigger than the research, right? It's got to be thinking about taking the time to really get to know community and to know members in the community and get to know and participating in the things that matter to them, right? And so she talked about, that one example where she wanted to develop a relationship, right, with someone in community. They'd say, come to Friday Night Lights, right? Come to our, ball game, right? I remember working in Granville, South Carolina, and I would go to their church services because that mattered to them. And that was something that we could communicate and align on. I went to communities not only when it was time to do data collection, right? And so really demonstrating that the people that you're working with are bigger than the data or what you can get from them, I think does go a long way. Yeah. There are others here that I won't call by name, but I know you work in community and you may not represent the community that you work with. And so if you have any practical suggestions for Kim, I think this is a really great question and a great audience who can help contribute to a clearinghouse of responses for how to help.
I'll just say that if you choose to go with use like the CBPR type of research that, and this is just kind of coming off of what Dr. Ingram was saying, is that you want to be sure that you have the community support. So having some type of group that you work with, not just other researchers, but having a group from the community itself that can serve as advocates for the work that you want to do is important. And then also, once you've completed that work, going back to the community and allowing them to have an understanding of what they did in order to help the process out. Because a lot of times you have people who will, use members to get the research done, but then they fail to go back and tell them, how important their work was and what the results were and how you can move forward to, to help the community and continue helping the community. So I think a lot of times it's that establishment of them knowing that you're there for them. And once you do that, your sex doesn't matter, your gender doesn't matter, your race doesn't matter. None of that matters because they understand that you are there for them and not just there to create a name for yourself and make a bigger name for yourself.
Thank you so much for all of your input. I think it's just like a growing concern. It's not really a concern. I mean, it is, but it's more of like present on my mind. And obviously community engagement is like so important. So I appreciate your engagement and attempts at answering a huge question that there's no answer to. So thank you so much.
Thank you for the question, Kim. Anything else for Julie? All right, well, seeing none, please do join me in thanking Julie as well as our other speakers for today. This was really a fantastic show of all the work and collaborative relationships that we had with our center and all our projects and networks. So I will begin our closing remarks a bit early. So what a full day. Again, thank you to our speakers and to all of you for joining us. We hope that you all had an enriching experience during your time with us. And before we close, we do have a few brief announcements. So number one, you will each receive an email from the conference center or from Quentin McCollum actually with an evaluation survey attached to it. We value your feedback on this experience and highly encourage each of you to complete this very brief survey. Now that you know all there is to know about our National Alzheimer's Disease Registries, we want to encourage use of these amazing repositories of information. Affiliated with the conference is a mentored interactive workshop for underrepresented minority scholars with a terminal degree who are interested in developing a research project using Alzheimer's disease registry data with the support of a mentor. Scholars who are selected will complete their project over the next 12 months and be invited to present their research at the next annual National Conference on High Impact Alzheimer's Disease Registry Research. To learn more about this opportunity, please contact our program coordinator, Mr. Quincy McCullum, and we'll put his email address in the chat for you. Lastly, we value community. If you want to learn more about the work that we are doing as part of the Carolina Center for Alzheimer's Disease and Minority Research, please also email Quentin so that you can join our listserv. And lastly, on behalf of my colleagues, Dr. Sue Lefkoff and Daniela Friedman, and our conference planning committee, I would like to thank you for attending our second annual National Conference on High Impact Alzheimer's Disease Registry Research. Special thanks to our team behind the scenes. Y'all can show screens if you like. Quentin McCullum, Megan Austin, and Kim Flicker for making today run seamlessly. And thank you to our funder, the National Institute on Aging, for supporting this conference. We hope you have a safe and healthy weekend. Thank you so much.